Hello and welcome everyone to the Oregon Office of Rural Health MBQIP Educational Webinar Series. Today's presentation is titled Quality Improvement 101. My name is Carrie Beck and I'll be your facilitator for the event today. This event will be recorded. This recording, the slides, and other materials used during the webinar will be available on the Health Insight website, and we'll notify you when these are available. Again, my name is Carrie Beck, and I am a project coordinator with Health Insight Oregon. Health Insight has partnered with the Office of Rural Health to provide education, technical assistance, and opportunities for peer-to-peer sharing for critical access hospitals participating in the MBQIP project. We have scheduled a series of webinars and roundtable calls through July, and we will also be hosting a workshop at the Rural Health Conference in October. You should have received Outlook appointments for all of these events. If you did not and wish to participate, just let me know and I will add you to the contact list, and then you will get all the communication. Also, feel free to forward the appointments to your colleagues who are interested in participating. Next, I'd like to call your attention to the chat feature. Feel free to use this feature throughout the webinar to share your thoughts and post any questions you have. There will be time for questions toward the end of the session, and again, feel free to chat in these questions and then we'll make sure to answer them during the Q&A. We will be using new technology called Zoom for our web conference today. Zoom allows for you to use your computer or your phone for sound, but in either case, please ensure your line is muted when you're not talking. Our presenter for today is my esteemed coworker, Jennifer Wright, and I will turn it over to Jen now to introduce herself and start the program.
Thank you. Oh. Now we were echoing. All right, sorry about that. New technology, it's the best. So again, my name is Jennifer Wright, and I am a little bit about myself. I am a licensed nursing home administrator, and I tell you that simply because it applies to a little bit of what I believe people do in critical access hospitals, where you deal with lots and lots of regulations, and you have a small staff that wears lots of hats, and so it just kind of lets you know that I've kind of been where you are, although I haven't worked in a critical access hospital. I have worked in a similar type of environment. And then also that I do have a quality improvement background. I do have my certification, Certified Professional Healthcare Quality, and I've been teaching root cause analysis and rapid cycle improvement for about 7 years now. And then the rest of my job, I work with communities to improve care coordination through working together, and hopefully the end result being we prevent admissions and readmissions to hospitals. And if the computer will cooperate, there we go. For those of you that are unfamiliar with Health Insight Oregon or haven't heard of us in this particular name, under this particular name, Acumentra Health may be more familiar to you, or if you're really old school, we were OnPro way back in the beginning. We've been functioning as the quality improvement organization for Medicare in the state for about 30 years. But we recently merged with Health Insight to become Health Insight Oregon. And so essentially we're a healthcare quality consulting firm. We hold lots of contracts and subcontracts. The bulk of our work is these top 2 contracts you see here. The Medicare 11th Statement of Work, which I'll read off kind of the list of all of the projects that are in that in a minute. We have external quality review, where we work with the Office of the Oregon Health Authority, and do some quality review of the CCOs. And then we also, for those of you that may be familiar with the Oregon Care Partners project around dementia and medication safety and older adults, We are a subcontractor on that project, and it also takes a fair amount of our time. So the Medicare 11th statement of work encompasses lots and lots of little pieces that each have a letter and a number associated with them. And if we aren't paying attention to what we're saying, we sometimes refer to them that way. But briefly, they are Everybody with Diabetes Counts, which is around self-management programs and helping people become more activated in their own health. We work with the Million Hearts campaign and do cardiac training. Some of you may be familiar with our monthly webinars that are put on through that project. We work with nursing homes, reducing antipsychotic medications, and also are kicking off a new project to reduce the incidence of Clostridium difficile infections. The project that I lead and spend most of my time on is care coordination, and the ultimate goal with that is to reduce admits and readmits to hospitals. It also has a subcategory under it of reducing adverse drug events, and we prefer to call it increasing medication safety. We are focusing on the big three, which I'm sure you all have heard of: the opioids, anticoagulant medications, and then diabetic agents. We additionally have a hospital clinic data reporting piece of the contract. We have immunizations project where we're working to increase the pneumovax and flu vaccines and raise awareness for those two vaccinations. We have a behavioral health portion of our contract around increasing depression and alcohol misuse screens and decreasing readmissions to behavioral health. And then we have a new piece of the contract around antibiotic stewardship, where we are looking to improve or decrease the use of, improve the use of antibiotics in a more reasonable fashion. And actually Carrie, Beck is leading that project. So that is the giant overview of all of those projects. If any of them piqued your interest at all, please feel free to contact Carrie or I, and we can hook you up. And now on to what we're actually here to learn about. Root cause analysis. We're going to talk a little bit about root cause analysis. We're going to use the Institute for Healthcare Improvement's model for improvement. We'll walk through some rapid cycle improvement using the PDSA. Interesting that we wrote Plan, Do, Check Act here. Plan, Do, Study Act, they're all the same thing. And it's just a way to do some rapid cycle improvement. And then we'll do a quick wrap up and questions. So our objectives today are hopefully to refresh your knowledge of the basic quality improvement principles. For many, if not all of you, this will be review. And here's my little pitch where I put in that adults need to hear something 5 times in order to learn it, because we're currently slow learners as we age, or slower learners. And so if that's the case for you, that this is not new information, this is one of your 5 reviews. And hopefully, again, by the end, you will have gained some ideas for approaching challenges using some rapid cycle improvement methods. And then we're going to talk a little bit about reporting and why it's important. So let's just jump right in. What is root cause analysis? Root cause analysis is a way of identifying a problem in such a way that you can determine what happened, why it happened, and how you keep it from happening again. The formal definition is process for looking at unexpected events and outcomes to determine the underlying causes or contributing factors and recommend changes that are likely to improve them. So again, that's a little bit longer-winded way of saying what happened, why did it happen, and how do I keep it from happening again. The philosophy of root cause analysis is that you want to focus on systems and processes and not individual people. You typically, the easy fix is when somebody falls or something happens that that person wasn't being attentive enough to when they were caring, or when in reality there's likely a system that set that person up for failure. Very rarely in healthcare do we find people that are intentionally trying to create problems. Granted, there are a few out there, but the majority of us got into this business and industry to help and care for people, not to hurt them. So additionally, you need to understand the true problem. And when I say that, I mean that there's lots of different things that might be the problem, but understanding the true problem that you're focusing on is important, because if you're going to find the root cause of a problem, you need to make sure that you have all agreed on what that problem is. And again, root cause analysis uses a system approach versus a symptom approach. So you might think of symptoms as band-aids, whereas systems are more of a long-term fix. And so some examples here are, like I talked about, work or carelessness, when in reality the results are often defects in the system, and people are just part of that system. And so making sure that we have our systems set up to improve their ability, to enhance their ability to do the right thing. And then my visual, how do you kill a weed? I think this is really appropriate for most people that live anywhere where green things grow. Those of you that are gardeners, I am not. I grow weeds really well, but that's about it. Know that if you pull the weed and you get just the green stuff off, or the brown stuff, or whatever it is, depending on the season, you're going to get that weed back. And of course, you need to get the root in order to kill the weed. And so if you think of the weed as the symptom, meaning the roots create the symptom, the weed, and your underlying causes are, of course, the root system, you have a nice visual for how root cause analysis hopes to root out your problems. So we talked a little bit about understanding the problem, and you need to define this as a group. So your initial information is going to come to you perhaps via an incident report, or a complaint or a concern from a family member or a staff member, or a patient, or perhaps you got a data report that showed a trend that you aren't very happy with. And so deciding what you want to correct is really important. There's not a lot of things you need to agree on when you're brainstorming and doing this type of a process, but the problem itself is the one thing where everybody in the room should agree. And ideally, when you're doing a root cause analysis, especially on a more in-depth problem, you have an interdisciplinary team in the room, so you have representatives from various different departments, and maybe even departments that you wouldn't necessarily pick or think about, but making sure you have a good variety of folks in the room will help with this brainstorming process. So for instance, if you had a fall like we talked about, it may be a side effect of a medication, it might be that they had a dizzy spell. There's lots of different things that you might define as the problem, or you might as a group decide that the fall itself is the problem and that the other items, the medication or the dizziness, are symptoms of that problem. So again, just making sure that you're focused on one problem so that as you walk through this process, you have the same end goal in mind. And of course, we all know that the healthcare industry, and I think any industry, but in an industry where you're helping people, there's all sorts of underlying contributing factors that can come into play. And so this just gives you kind of another visual of all the things that might have helped that problem to become a thing. There's also a visual of Swiss cheese, and if you think about Swiss cheese, and it has holes in it, each slice has different holes. And so you have barriers in place to keep problems from happening, but every so often all the holes in the Swiss cheese line up and something gets through all of your systems and things that you've set up. And so it's a good time to review and having all of these things that might be contributing to the problem. They're each a different slice of the cheese. And so just remembering that complexity is a thing and it's okay, and being a little bit extensive in your brainstorming and thinking about these contributing factors is a good thing. So the next piece is filling in the gaps. And as we're walking through all of these steps, you'll notice that they feel sort of maybe redundant or simplistic, or both. And that's because often we, as highly functioning individuals who have been in healthcare for quite a while or been humans for quite some time, have the ability to think about many things at once, and we problem solve quickly. And so these steps are happening simultaneously in your mind, but when you're teaching something, you of course need to break it down a little bit. So filling in the gaps is, you get an incident report and something happened and you don't know who witnessed it, or you don't know what time of day it happened. Typical things, and you realize, oh, I need to go ask somebody that question. And filling in the gaps is going to happen several times during the process, where you might be partway through your root cause analysis, and we'll talk about the 5 whys, and you get to a why and you don't know the answer, so you need to go and find out. So this is just something that happens, but it's, again, one of the steps in root cause analysis. This is kind of the meat of root cause analysis, identifying and analyzing your root cause. So this is where we want to figure out what conditions allow the problem to happen, what other factors may have impacted the problem. Are there additional underlying reasons or causal factors that we aren't thinking about? And again, that's where that multi or interdisciplinary team will help to come up with those. And then lastly, we want to think, as we're moving forward, about impacting the contributing factors. Is it something that you actually have control over? And that's something that you can do after your brainstorming, but it'll be an item you want to consider. So we use something called the 5 whys, and it's a question asking method that was actually made popular in the 70s by the Toyota production system. So Toyota is one of those companies that comes up a lot for their methods of fixing problems and getting systems to run really smoothly. It's basically you just ask why, and then you can, once you've uncovered a root, we can move into a root cause, rather we can move into some rapid cycle improvement. So the 5 whys, again, is a simple question asking method. This is a little example I'll give you, and of course it has exactly 5 whys in it because it's an example, and so when we're in the pretend world, we get to make everything perfect. In real life, you might ask why twice and arrive at your goal, or you might be asking why a whole bunch of times. One of the best examples of lots of whys is, I actually saw a chart of essentially the 5 whys done on why the Titanic sank. And it's a giant visual where they asked many, many, many questions. So just remember that complexity is relative. And so in our example, we're gonna, again, this may or may not be true of me. I actually haven't gotten a speeding ticket. Other than that, I do tend to leave my house late. And so we'll say I got a speeding ticket on the way to work. Why did I get a speeding ticket? Because I left home late. Well, you might say solution to that is to leave home earlier and then problem solved. And granted, that may be true, but that's pretty much a Band-Aid fix. If I haven't left work earlier before, or left work early, don't tell anyone. If I haven't left home earlier before, there's probably a reason. And so if you continue to ask why, well, because I slept through the alarm clock. Why'd you sleep through the alarm clock? Because I was too tired and I didn't hear the alarm. Well then, get a louder alarm. Again, that might actually solve the problem. You never know. I can tell you from experience that having multiple alarms or alarm across the room doesn't always work for me. I have quite the ability to get back in the bed and go back to sleep. So why ultimately are you too tired? And well, I went to sleep too late. But why did you go to sleep too late? I wasn't just sitting staring at the wall. I actually stayed up to watch The Late Show. That's also not true about me. I tend to watch it on YouTube, but you know, perfect world. And so our plan here would be to record The Late Show and maybe watch it at an earlier time the following day so that you can go to bed at a more reasonable hour, get up, leave home on time, et cetera, et cetera. Again, very simplistic example, but it's a nice little visual. I also have a little proverb, I guess you would call it, of what I consider to be kind of a 5 whys in reverse. And it goes like this. For want of a nail, the shoe was lost. For want of a shoe, the horse was lost. For want of a horse, the rider was lost. For want of a rider, the message was lost. For want of a message, the battle was lost. For want of a battle, the kingdom was lost. And all for the want of a horseshoe nail. And so if you were to start with why did we lose the kingdom and go backwards, you might find out that it was because we didn't maintain our horseshoes well enough. And again, it can come down to something just as simple as that, or it can be a more complex answer. So once we have a root cause, it's time to develop an action plan. And here's where we talk about the model for improvement. This is a model that the Institute for Healthcare Improvement uses. It was actually developed by Associates in Process Improvement, and both links to both of those will be later in the presentation for you to check out if you want more information. And the Model for Improvement is a simple tool. It has two parts. It asks you 3 fundamental questions, and then you move on to do a PDSA or Plan, Do, Study, Act rapid cycle. It looks like this. The 3 questions are, the first one is kind of your aim or your goal, and it's your big overarching, what are you trying to accomplish goal. How will you know that that change you made is an improvement is how you measure. So you have to make sure that you know where you started and where you finished in order to figure out if you actually made an improvement. And then finally, what changes are you actually going to make that will result in an improvement? And once you have those 3 questions answered, you can move into your first test of change. This document is available on the website to download along with the slides and with this recording. This is a really easy to use sheet that can walk you through doing or setting up a test of change for yourself. And as we walk through our example, this will be kind of the format that I'm referring to. So in our example, our first question is, what are we trying to accomplish? And when we think about our aim or our goal or the thing we're trying to accomplish, we want to make sure that we have it, that it fits into a SMART goal. You may have heard of SMART goals, or there's lots of different acronyms for it. This one is one that we've adopted, and the second S is an addition that is made sort of, I think, more in healthcare than anywhere. But it stands for specific, measurable, achievable, and realistic, and that means that it's achievable and realistic doesn't mean easy, but it means that it's something you can achieve. Your goal shouldn't include things like world peace or going to the moon in your car. Okay, so those are a little extreme, but just make sure that when you think about this, that you're stretching yourself, but not so far that you're going to become frustrated at not accomplishing your goal. You want to make sure you have a time frame around your goal, and supported is that not only the people that are writing up the change or talking about the root cause analysis or what happened, but the people that are actually going to do the work are supportive of the plan you're putting in place. And so back to the interdisciplinary team, having those people in the meeting in the first place will help you achieve this supported piece of the equation. So we are going to, this is our goal for our pretend world here. We have decided that by March 31st, 2017, we are going to reduce our door to diagnostic evaluation time by 10%. For those of you that are interested or following along, that's an MBQIP measure, OP-20 or OP20. I'm honestly not sure how it's most often referred to, but it is an actual measure and something that can be frustrating to try and fix, especially with various regulations and things in place. So we're going to try and work on it. And how are we going to do that? So we need to figure out first how we know that our change is an improvement. So what is our measure going to be? And in this case, we're going to say that we're going to track our door to diagnostic evaluation time by reviewing our data weekly. And that may be data that you collect, so you may create a form that you're going to collect this data on. It may be something that you can get out of your electronic health record, or that somebody else tracks and you just need to review. That's something that you would figure out as you walk through this process. And finally, what change are we going to make that's going to lead to our improvement? And so in this case, we are going to hire paraprofessionals or a paraprofessional to perform the initial diagnostic tasks when somebody comes in through the door, and that will reduce our time. So we have decided what we're going to do. We've decided how we're going to measure it. And now we need to actually recommend and implement those solutions. So we've made our recommendations. We're going to implement them using a PDSA cycle. And so PDSA is an acronym, again, for Plan, Do, Study, Act. And it's a way to move yourself through a process that will eventually get you to a change. But it's several steps. And so as we're doing this when we're assigning step, or when we're doing our plan, we will assign each step to someone, and then we'll go back and we'll review what we did and decide how we're going to go on to our next step. So like I said, we're going to use the PDSA cycle. It's simple. It reduces risk by starting small. Change is scary, and especially for those people in the front line or that are dealing with this out front. It can be really scary when you try and change something about the way they actually do their care or the way they've been doing their systems or data collection for a long time. And so starting small and testing it takes away some of that fear and that concern. And then this will guide your planning and your implementation of the larger change as you move through your cycles. This is a visual that you can print out and hang on your wall and enjoy. It just gives you each of the little pieces of the PDSA cycle. It kind of also has some little tidbits to remind you what happens during each of those steps. Again, keep it simple. Make sure that you are setting up your small tests small enough that you can do something quickly. So what can we actually accomplish by next Tuesday? Now, this doesn't mean that by next Tuesday, we're going to have that professional on the floor, we're going to have someone hired, they're going to be working, and things are going to be going great. We're going to work through a PDSA process of testing our change. And so keep it simple, silly is the process here. So here's our plan. Our first test of change, our plan is going to be to hire a temporary nurse practitioner or physician's assistant. We're going to have to schedule that person to work during a traditionally busy time. And we will know that we have a traditionally busy time based on previously collected data. And that data may be just that everybody that works knows that this is when we're busy. And then we're going to track our door to diagnostic evaluation time. And so if you're following along on the sheet that we provided, or if you've downloaded that, you'll notice that there's steps there listed to execute the plan. And so this is where you're going to assign specific people. And so we're going to say that we're starting this process on February 1st. And so we're going to get this temporary nurse practitioner approved by the C-suite, because you can't just go and hire somebody typically. You need somebody to approve that budget outlay. And so Sally is going to get that approval by Thursday, February 2nd. Or maybe we're starting this on January 31st, so we're giving ourselves 2 days. And then we're gonna say, yep, that'll work. We're gonna call a temporary agency and request this type of professional. Again, this is probably gonna take some time, but actually making the request doesn't take too long. And so Jane in HR is gonna do that by Friday, February 3rd. And then, of course, we're gonna need to get this person in the building, and we're gonna need to get them oriented, and we're gonna pretend that we don't live in far rural Coos Bay or way out in Eastern Oregon, and that this nurse practitioner can show up at our doorstep on Monday. And so on Monday and Tuesday, Bill is going to train this person to the way that we do things in our emergency room and get them oriented. And then once they're trained, we'll go back to Jane in HR, who's going to get them on the schedule for our traditionally busy time. So you'll notice that I actually put names with those, and that's really important because we want accountability in our plan, and we want to make sure that we have specific dates. And granted, some of those dates we may not hit them, but we want to again set them to be achievable and realistic. Maybe a little bit of a stretch. Getting that done in less than a week is quick, but that's something that we could theoretically get done by next Tuesday. So then we're going to actually do our study, and then we're going to do our plan rather, and then study our plan. So our dues portion of this activity is that our new nurse practitioner works in the ER in the evenings for 2 days before, during, and 2 days after the full moon, because everybody knows that the full moon evenings is always a fun time in an emergency room. And we track our door to diagnostic times while this nurse practitioner is working and see what we've come, and then we'll review them during our study. And so really quickly, I want to point out that it took us about a week or so to go through all the tasks of hiring or getting this temporary person on to our team, getting them basic orientation, and getting them scheduled. And then our actual test is only 5 days. It's the 2 days before, the day of, and 2 days after the full moon. So very short rapid test of time. It's one person for 1 week. And so after we have completed our test, our team gets together and reviews the data, and it compares it to we compare it to the last full moon average door to diagnostic times. And again, if you don't have this data already, you might need to actually collect some baseline before you try and do a test, or you won't know if you've improved anything. And so that's part of the process. If you know that you don't have baseline data, then take the time to collect that before you try and implement a change, or you won't know if you've made any successful strides. And so it turns out that our data show an 8% decrease in our average door to diagnostic time. And remember, we were hoping for a 10% decrease. So now we need to decide how we're going to act on what we've learned. And in this case, our team decides that we're going to run the test for a full month, and we'll see what the data show at that time. And so typically when you make an action on a plan, you're going to adopt the plan because it worked flawlessly. And so now it's time to adopt it and spread it. And so next you might do that same person for a whole month in the evenings, or you might do evenings and nights. But you don't want to do a whole month for evenings and nights as your next test. It's spreading it a little bit at a time, but enough to where you can see a change. And then you know too that you're putting a little bit of pressure, if you will, on your test to give it, see where those failed points might be. So adapting it is, it kind of worked, but we want to change one thing or another. And so in this case, we're kind of doing an adaptation where it worked, but only got an 8%. So we're going to see if maybe we actually need to run it for a full month before we make a decision rather than just the 5 days. But because it did make a positive change, we're going to go ahead and move forward with it. Or you might abandon your plan altogether. It doesn't happen often, but sometimes you think, you know what, the nurse practitioner made our times worse, and we are just going to abandon this, or maybe we're going to go way back to the drawing board and start again. And so those are kind of the 3 or 4 or 3 things you might do in your action step. So as you work through this process, you start with a hunch or a theory, and in this case, we decided that because our doctors have time to get to us when we have an emergency, and they're expensive, so we don't keep them just sitting around in the evenings, that we might be able to afford to have a nurse practitioner sitting around a little bit. And we got that hunch or that theory, and we started testing it. And so the more you test, you continue to change, you learn a little bit, you adapt your PDSA and do another one, you expand it, and you start to realize that, as you're doing that, you're learning. And at the end of it, you have a change that results in improvement. So eventually, you have maybe a nurse practitioner working 24 hours a day, 7 days a week. I don't know. But depending on how your PDSA works out, you have a change that results in improvement. So like I said, these are additional resources for you. I've included here the Institute for Healthcare Improvement, Science for Improvement, the API website, a little bit about Toyota if you're interested, just a little bit of trivia history. And then also, because we're going to talk a little bit in a moment about reporting, the Oregon Critical Access Hospital Quality Reporting Overview Guide was written by our very own Namrata Dav, and it's excellent. It's where I learned everything I know right now about measurement and how best to do it, and it's very easy to understand and straightforward. So here's a moment for you to ask some questions. For those of you that are listening to the recording, please feel free to email any questions you may have, or give us a call. Again, our contact information is at the end. And you just thought you were done, but wait, there's more. This is like one of those ads. By the way, that was my puppy dog. I hope that by the time you've listened to all of this, you don't feel like my puppy dog hiding under the blanket. But just something besides a blue line and an ORH and a health insight thing on the page seemed appropriate at that moment. So quickly, let's talk about some reporting and why would you want to do it? Like the WIFM, right? What's in it for me? The MBQIP measures are not all required, and so sometimes it feels like adding the extra workload doesn't make any sense. and you wonder, why would I want to do this? And so here's a few things. Again, I got most of this information out of the overview guide. There's lots of good ideas and help for how to go about reporting. But keeping in mind that it will satisfy your copy efforts under your conditions of participation. And that each year, the minimum requirements for those flex funds increase. And we all know that's the case, that how we get our money gets harder, and that they're eventually going to require us to do all this stuff anyway. So if we can figure it out now, when it's not required, and make our mistakes, then by the time it is required, it'll be no problem. And then, of course, for your root cause analysis on PDSA, you want to use, it will give you data to for your comparisons and to see trends. So if reporting is something that you're struggling with, and a lot of times it's because you don't have time, or you don't have the staff, or you feel like you don't, this is one of those areas that's a really easy thing to do a PDSA on, to figure out what is your root cause. If you don't feel like you have time, what's taking your time, and do some of those tasks need to be reassigned, or do you actually need more people, and can you justify that to the people that hold the purse strings? Is there any room in the budget? Those sorts of things. And so these measures are important and can feel overwhelming, but if you break it down into a nice PDSA, sometimes that will help you overcome and get your measuring done. So just to wrap up my section, and then I'm going to hand it back over to Carrie for a few last minute announcements. Today we talked about quality improvement principles, just a basic refresher, and we discussed some ideas for approaching our challenges using some rapid cycle improvement. And again, it can be small problems, it can be big problems. And then we talked a little bit about why you want to report your MBQIP data. And again, if you have questions or comments, please feel free to email or contact us, and we'll be happy to get you in touch with someone that can answer your questions if it's not us. So with that, I'm going to hand it back over to Carrie.
All right. Thank you so much, Jen. As I mentioned earlier, technical assistance provided through this partnership with the Office of Rural Health will also include a series of roundtable calls, which will follow webinars. This is a time, or this time is an opportunity for all of you to share and learn from one another. So we hope that you will participate in those. We will also use Zoom technology for these roundtable calls, and Zoom allows for video conferencing, and we will use the video feature from our end, and if you have a camera to turn on from your end, you are welcome to try it, and we encourage that. We'd love to see your faces. So in conclusion, an evaluation will be, a brief evaluation will be emailed to you following the webinar, and we hope you will take the time to give us your feedback. And here is the contact information for Jen and myself, and as Jen mentioned, feel free to contact us at any time. All right, that is it for today. We will be signing off now, and we hope you have a great rest of your day.